Hello, everybody. Good afternoon, and we'd like to welcome you to the first discussion in our webinar series, COVID-19 Forum, How Coronavirus is Reshaping the Future of Home Health and Hospice. Before we begin, I want to go over just a few items so you know how to participate in today's event. You're listening in on your computer speaker system by default. If you'd rather use the phone, just go ahead and select telephone in the audio pane and the dial-in information will be displayed. You can submit questions to today's panelists by typing them into the questions pane of the control panel. We anticipate taking the full hour to cover today's topic, but we will address all questions in an FAQ following the webinar. We'll also share today's recording by email. This webinar series is brought to you by Healthcare at Home, the Rowan Technology Report, and HealthRev Partners. Published by home care technology consultant and today's moderator, Tim Rowan, the Rowan Report is the most authoritative and respected technology news source in home health care, gathering, delivering, and interpreting news about home care technology, regulations, marketing, and other important issues. HealthRev Partners is a revenue cycle management company that takes a tech-driven consultative approach to coding and billing, producing measurably higher results without the higher costs. We deliver tailor-made RCM solutions that address each of our clients' specific goals and challenges, providing detailed insight into operations and performance. Now let's get started. As frontline healthcare workers during COVID-19, you're faced with the challenge of providing care under circumstances really never before seen in our lifetime. So to that, today we're going to be discussing the adaptations and changes and innovations in patient care that agencies just like yours are making to address this pandemic. We're also going to chat about how the changes you're making now could affect how you manage patient care in the future. So with that being said, I'd like to go ahead and introduce you to today's panel. Christine Flynn is the Director of Supply Chain and Operations Integration at Hospice of Michigan. Joining Hospice of Michigan in 2001, she's responsible for the oversight of daily operations, financial management, and process improvement for all contracted patient-related services within Hospice of Michigan, Arbor Hospice, and its affiliated programs. Next, we have Darcy Trisconi. She is a business development and information systems consultant in the post-acute healthcare market with a strong background working with both home care and hospice providers and vendors. Darcy presently writes for the Rowan Report and has been published in Caring Magazine. Additionally, she's conducted educational sessions for Decision Health, NOC, NHPCO, and a whole lot of state associations. Kathy Pate is next. She's the CEO and co-founder of Corstrata, a virtual wound care management company. She has operational experience in launching and leading new post-acute tech-enabled service offerings by applying customer-centric and quality improvement methodologies for aligning with emerging value-based care delivery, including accountable care organizations and bundled payment for care improvement initiatives. And our final panelist is Mary McCammon, Director of Education and Quality for Abilis Health, a large home health provider in Tennessee. She has 32 years of nursing experience with the last 15 years in leadership roles in home health. And we are very lucky to have Tim Rowan as the moderator for this webinar series. As I stated earlier, Tim is a nationally known home health care consultant and the publisher of home care technology, the Rowan Report, which has become the industry's most widely read journal covering technology and regulatory issues for home care providers. Now I'm going to stop showing my screen and I'm going to turn this discussion over to Tim.
Thank you very much, Megan, for that great introduction. I'm a little bit flattered, but happy to be the one bringing testosterone to this conversation. I have a lot to cover, so let's get right to it. We have a very serious topic this afternoon. All of us have had our lives changed quite dramatically by the pandemic. Some of us as frontline responders, some of us in support roles to those responders, and some of us even in our cities and our families. So let's get into the implications for clinicians and for patient care. I'd like to start with a question specifically about providing patient care. How disruptive has COVID-19 been with regard to patient care? And we're going to try to coordinate this by taking it alphabetically. So I wonder if, Christine, you would start off. Oh, you're still muted. Nope, still can't hear you. Tell you what, you figure it out, and we will jump over to Mary for a moment. How's your microphone working, Mary? Oh, there you go. Okay, sorry, Mary. Christine, we can hear you now.
Can you hear me now? Perfect. Thank you. It was very disruptive for us in the state of Michigan. We really turned the corner very quickly on the virus. Literally, it was business as usual on Thursday, and Friday it was a complete shutdown for the state of Michigan. So we had to turn corners very quickly, come up with a plan very quickly of how we were going to prioritize and care for our patients. We definitely had emergency plans, and we had systems in place, we thought, to manage these types of situations. So we were prepared for most aspects, but this is something we've never experienced before. So there were so many new things that we didn't think of and that we have never been faced with. So it was definitely a challenge, but something that we've grown and worked through, and it changes daily. There's new orders that come out daily, businesses open up daily, and things change daily. So it's definitely not going away, and it's something we're going to live with for quite a while.
Christine, you're in a state where there have been some pretty severe shutdowns by the governor. Has that impacted patient care too?
It's impacted the whole state. It's impacted our patients and families. One of the big things that has been a challenge has been pharmacy. If you're utilizing local pharmacies for many of your patients, the hours were reduced. The ability to get medications has changed. DME companies had very difficult time servicing patients, allowing patients and families allowing services into their homes. So it was definitely something we've never dealt with before.
Darcy, you're originally from Michigan, but you work with home care and hospice organizations all over the country. How have you seen patient care affected?
It's been extremely disruptive. If you think about just in general, the hospitals deciding to stop elective surgeries or surgeries, regular treatments that patients who are already compromised really need, they're starting to do them again, but those patients have now sat for months needing these surgeries, and they're more compromised than they were before. Not to mention, we haven't had, from a home care and hospice standpoint, we have not had access to get inside facilities to see the patients that we're currently seeing before COVID hit. So we've had to really think outside of the box on how we get to those patients. There's also been a lot of education with patients because some patients wouldn't even let us in their homes for fear of, transmission. And it's just been, it's affected all areas of our healthcare system, all the way from hospitals to nursing homes to independent communities to home care to hospice to everything. And all of the suppliers for those healthcare organizations have been impacted as well.
Kathy, you have a wound care company. What have you seen?
Very similar things to what Darcy was just explaining. We provide outsourced wound and ostomy management to the post-acute care settings. So we're in rehabs and nursing homes and home healths and hospices. And across the board, we have seen challenges in terms of both staffing for those particular care settings, as well as patients refusing visits. So challenges with that, as Darcy explained. I think that in addition, I think Christine mentioned that there were the cessation of planned surgeries has definitely made an impact in terms of census on in both the home health space as well as the rehab facilities. So yes, every facet has been both on the clinical side and the clinicians providing the care and on the patient side.
Mary, you and Christine are the two providers among us. What has been your experience at Abilis?
Well, I think the same for everyone. It was a mad dash in the beginning. It was just all consuming. We were in a rush to keep up with the information, to find the information. And like Christine said, of course, we had an emergency management program, but it didn't cover anything like this. We were rewriting policies, just almost daily as things were changing. And with us being spread out across the state, when shutdown started, it was kind of like a wave you could see as community spread in the different locations. That's where you saw census impacted. That's where we had refusals. And I have a unique situation because I actually live in Mississippi, right below Memphis. That's not an area that we cover, but it is one of the hardest hit. So a lot of especially in Tennessee, and so a lot of the restrictions that apply to me don't necessarily apply to where I work. So I've had to keep those straight, so I'm guiding correctly. And of course, something we've all talked about as well, just when you're crossing state lines, our employees coming into Tennessee, crossing counties where there are more rigorous restrictions, and it is just a daily thing to keep up with that and make sure that we are compliant.
Enough to juggle mobile employees. Now you have to juggle various county regulations as well. Mary, let me stay with you. Our next question has to do with admissions. Can you remember how admissions were affected toward the beginning when the pandemic first started, and whether or not that's changed over time?
Yes, so the end of February, we were pretty consistent. And then March, we kind of hung on. And then April is when we really took a hit on our admissions. We were probably 60 below what we normally would be. And then in May, we started coming back up. And of course, all the surgeries had started back. And then June, we're really back on track to do well. Now, that being said, there's still some things with the governors not reopening or not advancing to next stages. But so far, that has not affected us with the actual patient care and getting in to see the patients.
Christine, I would think that the experience in hospice might be different. What was your intake and your census like?
It was very interesting for us. We actually did not see a drop in census through all of this. We actually maintained our census back from when we started in March through now. But what happened was the census actually shifted. Because the facilities and hospitals had pretty much shut down in our areas, we saw an influx of home care referrals. But what was different is that they were very short length of stay. These were patients that were very sick, probably would not have been referred to us otherwise, but we were getting those types of referrals because there was really no other resources for those patients. They weren't allowed to go into skilled nursing facilities. AFCs and assisted livings were not able to take them, and families weren't able to care for them by themselves. So it was an interesting piece for us because we did not expect to see an increase in census or even to maintain or see that shift in home care volume.
Did you notice an impact from the problems that nursing homes were having?
Nursing homes in Michigan pretty much locked down, and many of them still are, depending on the areas that they're in. We have not been able to visit many patients in some of the facilities still. So that has been an ongoing challenge for us. But they were able, some of our areas that are more open and where the prevalence of COVID is less, We are back in those facilities now. We are seeing the referrals in those facilities again, and we're starting to see that shift.
Darcy, what about you with your work with various home care and hospice agencies? Have you seen an impact from the nursing home shutdowns and the large percentage of communicable disease infections that they've had?
Yeah, absolutely. We've seen it affect home care and hospice in a couple different ways. One is business development. Our sales executives can't get in the door. The other is patient care. If our nurses can't get in the door, that's a problem too. And, so what I found is that a lot of my agencies are taking the time to really build better relationships with those nursing homes, understanding what rules they can work together to improve infection control, how we enter a nursing home, who we talk to, that type of a thing. But it's a lot of restrictions. We're doing more virtual meetings with the staff in the nursing home, I've noticed as well. So it's changed the way that we facilitate care for patients.
Kathy, as a supplier of technology and of wound care services, you work, I assume, with both residential and home care. What kind of changes have you seen?
Well, I think that the pandemic has served as the tipping point for virtual health or telehealth. It really has made all the key stakeholders look at the value out of necessity for access to care. So on both the home health front as well as in the facility-based care, they are relying more on virtual care in order to provide access that is not currently staffed within that facility or within the home if the patient has refused visits. So we've definitely seen increase in the use of telehealth type of technologies and practice.
A number of telehealth companies have told me that their phone is ringing 10 times as much as it used to. Have you experienced that as well?
I have very positively. We've been impacted. It was a lot of the wound care centers that were co-located on hospital campuses were closed. So then those patients were even more vulnerable, because home care in many instances shares care with that wound care center, and those patients were not able to get into that wound care center and direct care. So the telehealth and virtual means of communication served as kind of a bridge to that care.
Mary, I think you might be the best one to talk to us about Casemix and referrals. Have you seen a change that you can relate to COVID-19 that has changed your average daily census, which we already talked about, but severity of the patients that are being referred to you?
Well, what we've seen, I think more than anything is, in the beginning when we were having a very difficult time getting into homes, we would just try to get nursing in there if we could just have a nurse. So our therapy numbers obviously went down at that point. We never had a huge influx of patients out of the hospital because it never got to a surge like that in our area. We were prepared. Many of our nurses were furloughed in the areas because they had brought in agency nurses, but there just weren't a lot of patients coming from the hospital. We have not taken care of a lot of COVID patients at all. Our referrals and census were affected by the closures of the facilities and our patient care liaisons not being able to do things. But like Darcy said, we did a lot of virtual things with our medical directors, with different referral sources, facilities on how can we best take care of these patients. And Of course, I'm sure like everyone across the country did, got really creative about how we were going to visit our patients outside of the assisted livings, and a lot of things that were really great that came out of it. So our case mix didn't change a lot until we have seen an increase in nursing and a decrease in therapy, but that has kind of stabilized itself as well.
Stabilized because now the joint replacement surgeries have picked up again.
Correct. We did have some, because we have a prehab program in some of our offices that the orthopedic surgeons have requested. We admitted patients that were going to have a face-to-face within that 30 days, and the surgery, and that actually never happened because the patient surgery was canceled and they did not go see their physician. So there were actually some patients that, you know, a few patients that fell in that we weren't able to bill for. And of course, we just readmitted when their surgery was rescheduled.
Christine, what about hospice? Has the severity of the patients at point of admission changed at all?
It did. It changed for us for a period of time. We had some very acute, very short stay patients. And again, I think that was just a result of there were not a lot of options for patients to transfer to, whether that was a facility, home care. These patients were definitely very ill. Overall, our volume of COVID patients, surprisingly, given our area, was not very high. Most of the patients that we cared for were in the facilities, but we were able to maintain and do the best that we can for all the patients that we had on service.
And what about policies? I'll stick with you for a second, Christine. Have you had to change any patient care policies or procedures? And if so, you're going to keep them?
You know, it forced us to look at a lot of policies that we haven't had to truly implement in a long time. We take for granted the everyday work that we do until something like this happens and it forces you to do something different. You didn't really look at things the same way. So yes, we definitely have identified some areas of opportunity to improve both the efficiency and the quality of care that we're providing as a result of this. But it's ongoing because it's still changing. I feel like as soon as we communicate we're going to do something and we've changed something, we're communicating again that it's changing again. So I think that's going to be ongoing, but I think there were some good things that we identified out of this time.
Well, it would seem that it makes sense that things change because the situation of the pandemic is changing, and it's changing differently in different states. Mary, over there in Nashville, have you had to change policies? And again, if so, do you think you'll hang on to those same policies after the pandemic subsides?
I do totally agree with what Christine said. We had policies that we had to relook at and update more than once. And I do think a lot of good things came out of this. We early on established a coronavirus hub that's our intranet, so the employees could access that at all times. And thankfully, everything we put out there, we dated. Of course, communication was daily, at least in the beginning, and then it kind of tapered off. But it would be very difficult to go back and figure out had we not dated that information. So it's definitely some policies changed, definitely processes changed. Of course, when we had people working from home, we saw a lot of efficiencies and a lot of things that we definitely want to expand upon, and just things that we hadn't looked at in the same way before.
You know, on a similar level, Mary, the way in which your actual caregivers behave and take care of patients, are they doing anything differently? I assume you have been able to get a hold of enough PPE when they go into the homes, but what kind of actual clinical changes are you noticing right in the home?
Well, as I'm sure most people did, immediately we implemented employee screening, a survey that's sent out on SurveyMonkey every day. And then depending on how the employee answered those questions, then it may generate another survey. In the beginning, we had some people that had done some international travel, even cruise ship travel. And so they, for 2 weeks, had to quarantine and monitor. And then we also immediately implemented patient screening that had to be done outside the home when they got in the driveway before they walked in. Because what I'm sure everybody identified is it wasn't just the patient, it was the family members coming in and out of these houses, and that you didn't know. So you had to ask the patients, had to know about the family. And we did a lot of education with the patients and their families early on. So I think that did decrease some of the amount of refusals that we had. We certainly have always focused on infection control, but obviously there was just an increased spotlight on that, and making sure that our patients are washing their hands correctly. And the clinicians made that fun. They would send in things that they had done differently with the patients, and some of them had cute masks, that the patients, that they would take the patients, or they would draw faces on their mask or something like that, just to make it not so impersonal. Because again, we haven't taken care of a lot of COVID patients, so there wasn't the full PPE, but we went to universal masking, and we let the patients know that was coming. We let them know why we were doing that, to protect them. And I think just the key all along, and I'm sure everybody would agree, was just that you can't over communicate in a situation like this with the patients, and just don't assume that anyone knows anything. And we did put out a lot of teaching for the patients, CDC guidance, and how to fix up their home, and what to do if someone's suspected in their home, and just tried to just take a team approach to think of just holistically and include everything that we could when the patients are going out to get their pharmacy or to see doctors and those kind of things. And just, again, a team effort, a lot of panels like this that we got a lot of great ideas from, and just we've really appreciated the sharing across the country. It's been really a great thing to see, actually.
Thanks, Mary. Darcy, I'm going to put you on the spot for this one. Yogi Berra said, predicting is very difficult, especially about the future.
Yes.
The second half of this question has to do with keeping these systems in place. What do you think? We know that the virus is going to be a problem for a long time, and we know that it's going to be a long time before there's a vaccine. So the core of the problem, the height, I should say, of the problem is going to be until there's a vaccine.
Right.
We don't know when. So what do you think about agencies that you deal with making these changes permanent?
I definitely think that they should. I think one of the things that this pandemic has uncovered is the holes in how we provide care. We're not using technology the way that we should be using to make us more efficient. And part of the issue with that is we don't see it as cost effective. But when you really sit down and you start looking at the remote patient monitoring and the tools that we're actually using, they are beneficial to the patient's treatment plan. And my hope is that as healthcare providers, we understand that sometimes we have to do things that may not appear cost effective to achieve better outcomes. And I am praying for reimbursement for telehealth. But yes, I think that these are a lot of the things that we're doing need to continue, because we don't know when the next pandemic's going to hit, and we don't know how long COVID's going to be around.
It's hard to plan for an unknown.
That's right. So it's better to just be prepared as much as you can.
Yeah, for any contingency.
That's right. That's right.
So, Kathy, this is your area. Just last week, the president of the American Telemedicine Association, Dr. Joe Kvedar, testified in front of Congress trying to convince them that we have learned the value of telehealth. Therefore, let's continue to pay for it and support it, regardless of what happens with the virus. Have you had insight into what the regulations might be as we move forward?
Well, you know, in the early COVID days, CMS was very forward thinking. They opened up the doors for telehealth. They erased kind of across state lines the practice for clinicians. They even said that telehealth could be conducted on non-HIPAA compliant platforms. I think some of that is here to stay. I think that everyone realizes that there should be some kind of national licensure, and that states may still want to recoup their, you know, the revenues they generate for those particular licenses, but that, you know, a nurse in Alaska is just equally as prepared to be a nurse in Florida, right? And that we have to open that up because it really provides additional access. I think that they'll probably roll back the HIPAA. I think that everyone using telehealth should probably be using a telehealth HIPAA compliant platform, because I think as we come out of the COVID days, that's going to be something reinstated. I don't think we're ever going to go back to pre-COVID in terms of telemedicine. I think what we forced were the different stakeholders. For example, physicians had been very reluctant to adopt virtual visits. Now, the pay wasn't, you know, there wasn't total transparency in terms of a virtual visit versus an inpatient visit. Now there's, you know, the reimbursement is comparable, but I think that they were forced to do it. And lots of them have had an aha moment. Oh my gosh, this is so easy. And then on the other side of the coin too, I think we've seen patients that were a little reluctant with maybe the technology, but because access was so critical to them, they kind of forged through the technology piece. And now that they understand the value, they know they don't have to go sit in the doctor's office and wait an hour, that they don't have to leave their home, you know, especially our homebound and hospice patients. You know, a lot of times it's a taxing effort for them to get to the physician. And this is a great way for them to access care. And, you know, lots of things can't be practiced virtually, but I think what people have realized is there's lots of things that can be accomplished virtually, as long as you have good processes. And I think that's key in order to make sure that your in-person visits are equally, you know, they provide equal assessments, et cetera, that it has to be the core forms and processes that you pull together that allow it to happen. So it's critical that you have that infrastructure in place in order to do so.
So with that background from a consultant and a vendor, we've got to turn to the two providers. Christine, you want to go first to talk about changes in the way you use technology that might become permanent?
Mm-hmm. I can speak for our entire organization that we had very many staff that were very reluctant to any sort of virtual type visit. Obviously, many of our clinicians were very familiar with talking with patients over the phone. But once you added that layer of technology where you can see the patients, it was very different for them. It was it didn't take hold as much as we thought it would in the beginning. It definitely took some coaxing on behalf of our staff to become very comfortable with that type of visit. Hospice is very hands-on. It's a very personal relationship with the patients, and the technological visits that we're now providing is very different for the staff, and they have to provide their visits a little bit differently than they would if they were face-to-face with the patient. However, I think long-term that we've definitely found the value in many of the visits that we've had. It certainly will never replace the hands-on piece that hospice provides, but there's definitely a place for it, especially after hours when a family member calls with just a question and they need to validate that they're doing something correctly, and they don't really want someone, you know, to drive an hour out to their house to just ask a simple question. We definitely find the value there, and I think that that will be long-term for us.
Well, in both hospice and home health, visits are intended to be occasional, right? Until the end of hospice, of course. But do you see this telehealth technology as replacing in-person visits or adding to them?
Adding to them for sure. We in hospice, it's very difficult to provide care unless you've actually seen the patient, seen the home environment, because hospice really treats the whole unit of care, the caregiver, the family, the patient. If you can put your eyes and your hands and see what that's about, and then transition to those virtual visits when it makes sense, I think it's an excellent supplement to the services that we provide.
Mary, in your role in home health, do you agree that telehealth visits would be in addition to the
Yes,
in-person visit?
I do. I agree. I think it'll be in addition to, and even the telephonic calls to patients in between make a huge difference. We have a lot of processes in place for acute care hospitalization and things like that that include telephone calls and with a scripted narrative, and even those seem to really make a difference. So that with telehealth visits and in-person visits, I think will just do nothing but improve our quality of care.
So do you intend to continue to use remote patient monitoring at the same level after the virus as you are doing now?
I hope we can. We don't have a real robust telehealth program. Our company is relatively new. So those were things that were in the pipeline. Of course, we got it immediately for face-to-face capability, and we have some diagnosis that we're going to focus on, but that is definitely something that everyone has seen the value of through this COVID that we already knew, but it has just increased that. So yes, I think we will.
Yeah, it's hard to go backward once you've seen the value of it. Yeah. Let me get a little bit more practical with you for a second. Stick with our providers for a moment. You can't turn on the TV news broadcast or cable anywhere today without hearing about PPE shortages or availability, or states trying to buy it from South Korea. Have you had any trouble? Christine, you go first. Have you had any trouble getting all of the equipment you need for your caregivers?
I will say it was a very interesting experience. I oversee our supply chain for our entire organization. So there was definitely some panic calls in the beginning. We have never experienced the word allocation in the way that we've experienced since COVID has happened. In the home care setting, I mean, we've always had PPE. We always use universal precautions. We've had that, but we don't get a very high volume of patients with infectious disease to this level that we've had to use supplies in this great demand. We definitely had our challenges in the beginning. We were very lucky that we never ran out. We certainly got very low. And then we were able to find some actually non-conventional type ways to obtain PPE that helped us significantly.
I hope you don't mean lawn leaf bags.
I don't. It was just, but we were considering all options. I'm not going to lie.
Mary, what happened with you in Nashville? Did you have any trouble?
Well, allocations became part of our regular vocabulary too. And of course, it was based on your prior month's usage. And we have infection control measures, but again, not to this level. Of course, we have TB masks that we always have on hand, and everybody had been fit tested and that kind of thing. But it was touch and go in the beginning, and especially as you heard throughout the news that they couldn't get the PPE, and we were preparing for the hospital surges, so you didn't want to take from those. But luckily, we found some outside sources as well that we were able to buy from. And our stockpile, actually, TEMA got together and they actually supplied, you put in requests and we actually got some from that stockpile. So it's tricky at this point, or a fine line, because we, you know, our efforts have been just aggressive conservation of using the proper equipment for the proper procedure. And then we also don't want to be stockpiling supplies, but we also want to be cognizant of, we don't want to be in that position where we're forced to buy things that, you know, either price gouged or things that may not, you kind of question the efficacy, you know, when you get the things that say some of these things made in these other areas, they were marketed like this, prepackaged in a different package, you know, those kind of things went to the back of the shelf, you know. So we maintain a weekly inventory, and we try to share from office to office so that, you know, we don't have things expiring. And but luckily we never ran out either, and the supply chain has been consistent.
That makes me think of another factor with regard to needing more equipment than you used to need. What kind of cost pressures has it put on your agency?
It was a big cost in the beginning. And of course, we were just looking for any source to be able to get it. But again, the pricing has leveled out, and our company was, like everybody's, committed to get what we need for our staff and our patients. So it was the most expensive in April and the end of March and April, but again, that's kind of leveled out now.
Christine, has the same thing happened in hospice in Michigan?
Yes, we saw in the beginning, it was shocking to see how the prices had increased. We were very fortunate to secure some very good resources, which was helpful for us. But the fear of fraudulent product, I think, was probably the biggest thing that our staff feared, because they heard so much about it on the news and in the media, that we put a lot of due diligence into making sure the products we're getting were appropriate, and there was going to be no issues with that. So that was very helpful in comforting the staff, because there was a significant fear in the beginning with not having the correct PPE, and just the fear of, we're a nonprofit hospice, so the cost of just securing bulk purchases to bring us through that was pretty expensive in the beginning.
You know, Christine, I have over the years noticed quite a difference when I interview hospice nurses as opposed to other nurses, any other nurses, hospital, home health, whatever. There's a quality of personality that draws somebody to hospice. And your emphasis, you know, all of us have an emphasis in the area of patient care and compassion, but hospice takes it to a different level. Can you talk to me about what you've heard from your field staff, from your nurses and other caregivers, about the barriers, the PPE gowns and masks, sometimes even plastic face shields? Have patients commented about it? Have nurses complained about it? Has it interfered in any way?
Well, one of the things that our nurses did was they explained to their families, I think someone mentioned this earlier, what those visits were going to look like. So when they were coming in, we had some patients obviously that tested, that were positive, and they explained to them how that was going to look. We had patients that were not, but we did also adopt a universal masking policy, and we requested our patients and families to do the same. So it did change the way that the visits happened. And because of the social distancing guidelines, we did try to acknowledge that as well. So a lot of the touch that's associated with hospice, I think, has been lost in some of our visits. our staff definitely communicated that they missed seeing their patients. The virtual visits did help in that they could actually see the patients and families, but they really missed having that one-on-one contact with them, because that's really the heart of what hospice is and what we do. So we're still struggling with that, because in some of our areas we're still locked down pretty tight, and face-to-face visits have not really opened up. And we've got staff really just asking, can I please just go see my patients? So it's a hard place to be, because their heart is so big, yet the environment that we're in is so challenging right now.
It sounds like it's a double-edged sword. When you see them in person, they're masked, you're masked. When you see them on video, you can actually see their whole face. It's good and bad implications and results. Mary, in home health, have you had any feedback from the field staff either about the barriers that the extra equipment poses?
Well, they I think were the most upset about the refusals of visits and just not being able to see their patients, certainly in the assisted livings, and just even missing each other in the office. They just, for months didn't come in the office, and we had to come up with a lot of other ways to get their PPE to them and things like that. So we haven't, business as usual pretty much now for our visits. We don't have people refusing, and just on a very, if there's been exposure in the home, that they've been contacted by the health department and they're supposed to social distance or something like that. But pretty much we're back on track with seeing our patients and not missing many visits at all. And just the education of letting them know why we continue to do the things that we do, and that just has gone a long way.
And they seem to accept that, even though they feel this barrier, this physical barrier.
Yes, but they're a lot better now that they are able to see their patients on a routine basis.
So as we get close to the end, I want to see if you can talk to me about lessons learned and any opportunities, as contradictory as it sounds, from this generational tragedy, the 100-year tragedy. What have we learned, and is there any reason for optimism going forward? Darcy, you want to kick that off?
Sure. I am hopeful, and I think that there is definitely a reason for optimization, or to be optimistic. I can't use the word. What did you say, Tim?
Optimistic.
Optimistic, yes. I think that we should be optimistic. I think that as vendors and ancillary suppliers of services and things like that start really looking at the holes that we've identified during this pandemic, I think that they're going to come to the table with better solutions for the industry. I think that we have all become aware that we need to start being more digitally ready to provide care, and that we need to find other ways of doing it, especially if we don't have access to those patients. And, infection control has become something that, we always paid attention to it, but I don't think we paid enough attention to it. And this has definitely changed the way that we live our daily lives. It's also changed the way that we provide patient care. So, I think there's a lot of reasons to be optimistic that we will improve, and we have learned lessons from this pandemic, and this just hope that we continue to evolve. We have to embrace technology. It's so important, and the data and the trends and all of that stuff that come from the technology tools we do have available, we need it in order to prevent the same thing from happening in the future.
Before this started, we talked about the staffing shortage being the biggest problem in post-acute care. Now you're looking at more use of technology that might incidentally soften or change some of that staffing problem.
Yeah,
Kathy, I'm sorry, go ahead, Darcy.
I was just going to say that I think that society as a whole, including our patients and their families, as well as our caregivers, have had to get to some kind of comfort level with the use of technology, and we will see that evolve.
Yeah.
So.
You know, Kathy, I've heard baby boomers say when we were kids, they told us by the year 2020 we'd have had flying cars, and now what we get is lessons on how to wash our hands. What kind of lessons have you learned, and what kind of reasons for optimism do you see?
I think, you know, I came out of the home care and hospice world as on the provider side before I co-founded Corstrata. So I have always been a huge believer in care being provided in the home. It's where the patient wants to be, and it is where the patient is safest from, you know, from infection. And I think what I see is I think we'll see a flip much more to the medical home model. I think people now understand that a high level of care can be given in that home, that it's the safest place to be. And I think it will bolster home care in the long run and in-home hospice. I truly believe that we have pushed it into a new way of viewing the value of in-home care.
Good. I have to agree with you that the thing that they have always told me is that it's not the fact that there are more germs when you go to a hospital, but they are different germs, and you're immune to the bacteria in your home, and you're safer there, even though it might not be as technically clean as a hospital. It's familiar. So
I think the payers too will start to embrace this and look at reimbursement from a different angle, that this is a more personable and really a more affordable way to deliver care.
you know, I've been here in home care for 26 years, and even before I began, people in home care and hospice were trying to convince payers and regulators that the more money you spend on technology, the less you spend overall. And within that, the more you spend on home care, the less you spend overall on healthcare. Maybe that's one of the things that will come out of this, is that they will finally hear that message. So let's wrap up with your forecast for the future. Christine, is patient care going to change permanently?
I believe so. I think the integration of virtual telehealth, I don't think that's going to go away. I think we'll see mixed models of care. I think more care provided in the home, as Catherine mentioned. I think people have seen the value in home care versus the complexity sometimes of going to a hospital or a physician office. So I think it's here to stay, and I think we can develop policies, practices, and agencies that are really good at it. So it'll be exciting to see how it evolves.
Mary, agree, disagree?
I agree. And I think we've all learned a lot as an industry, these Zoom meetings and panels, and just that we can learn from each other across the country. And I'm just so proud of our industry, just how everyone has reacted to this. And I think that patients will realize as well just the value of healthcare and healthcare in their home, and just what we can do to keep patients out of hospital, and just the fact that they have not been sicker and gotten the virus, and that, you know, there are safeguards in place. So I'm really hopeful to see the changes that we will see because of this.
As a consultant, Darcy, how does the future change for you? What kinds of advice you're giving to agencies with regard to your areas, sales, technology, and still as a nurse, patient care? You kind of cover the gamut. Will you be will you be changing in the future the kind of directions that you give to your clients?
Absolutely. I mean, I've always pushed for technology with my clients, but I've also understood the constraints because of reimbursement. I think that there are some creative ways that they can still maintain profit margins, or at least keep some profit margins by involving that technology. And so those are the types of things I'm working with them on. I think I go out and do a lot of home visits with nurses and working with point of care. I think we're going to see our point of care systems improve, and we're going to have to embrace that as well, because the documentation needs to be done at the home. So yeah, absolutely. And even in business development, I think that there are things that our liaisons and sales executives could be doing differently and utilizing technology as well, which saves their referral sources time. And anytime we can decrease drive time, we can see more patients. And that's what it's really all about, is making sure that everybody's getting the home care and hospice services that they need.
Kathy, you get to wrap up this section with regard to your forecast for the future. How do you see, I'm not even going to ask you if you see, how do you see patient care changing through the rest of the pandemic, after the vaccine is available, and if things ever get back to normal? What do you see? Are you hopeful?
Oh, I am very hopeful. I think there is permanent change. I think it's already occurred, and I think it will do nothing but go on and evolve and even get better. Technology in of itself is the equipment. It's how you utilize that technology and integrate it into your systems. And I think we were many were thrown into the technology world without a lot of that support of how to serve and utilize that technology and serve their patient population. So I think over time, we will have stronger interactions with the patients, because people are figuring out the systems and processes to put it in place. And I think we will continue to see an evolution of even bigger and better technologies that can do more than we ever imagined.
New inventions, which brings up the old adage, of course, about necessity. Yeah, I think you're right that there will be inventions, there will be new developments and better technologies. And we rely on people like you to find them and make them available to us.
That's what I love to do.
Well, we have covered quite a bit of territory today, and I'd like to kind of, before I turn it over to Megan to summarize, just point out one thing that we all know, and that perhaps we've learned even more today. You can talk about police officers, you can talk about firefighters and EMTs, but when it comes to a crisis like this, nurses are our heroes. In fact, I will throw in doctors. Doctors you can talk about along with cops and firefighters, but when it comes to the risks of their lives to take care of people, the 12-hour shifts and the exhaustion, I think all of our viewers would agree with me that we need to remember to be extremely grateful to people like you four and all of your RN counterparts and other caregivers. So thanks for being with us today. Megan, how you want to wrap this up?
I am going to share the last slide. Can you see it? Is it working?
Yes.
Awesome. Thank you. This was a great conversation. We have just gotten so much great feedback during this panel. So I really appreciate everybody joining us today, particularly to the panelists and to Tim. We hope that you all have enjoyed today's discussion. If you did, don't forget we've got 2 more forums coming up, one on July 9th, one on July 23rd. The next one on July 9th is going to cover financial operations. The final session will be about agency leadership and overall operations. I know there were a couple questions about turnover and retention. We will be covering that on July 23rd. So encourage all of you to register to attend those as well. We've got a great group of panelists lined up, so you do not want to miss it. To register, you will go to healthrevpartners.com/webinars. Once you leave today's webinar, you will see a survey pop up. We would appreciate if you would complete that survey and give us your feedback. You can also let us know if you'd like to learn more about Health Rev Partners or about anything that any of these consultants, vendors, agencies, Tim, anybody's doing. Let us know and we can reach out to them on your behalf. On behalf of Health Rev Partners, Tim Rowan, and our awesome panelists, we want to thank you for joining us, and we hope that you have a great rest of your day. Thank you so much.
Thank you all.
Thank you.